And now it's my pleasure to introduce the last speaker, that is Dietrich from the University of Frankfurt, to look what is most important in practice to the evaluation of fibrosis in this patient. Please, Christoph.
Yes, dear Johan, ladies and gentlemen, thank you so much for the invitation to present on non-invasive evaluation of fibrosis in NAFTAL patients. And I will go through the agenda. First, a few signs of steatosis using ultrasound. I will introduce elastographic methods, go for technologies of the different machines and techniques. I will compare results of two techniques in one equipment. Finally, one of the take-home messages is mainly prognosis depends on fibrosis and not on the fat amount. And then we will talk about different etiologies, age groups, eventually the fatty liver in very young patients, children's, and clinical decision-making. The sonographic signs of steatosis are, first of all, hepatomegaly. You can see the right liver lobe with rounded shape next to the arrow, and you can see some attenuation deeper to the kidney, and those are the important signs. Mainly it is echogenicity in comparison to the kidney. Or here you can see a normal liver parenchyma next to the spleen. You can see those close parenchymas in 1 out of 100 patients. And in the next image, in a fatty liver, you can see it's a bright echo texture in comparison to the spleen. And here in a normal liver, the normal liver parenchyma is more hypoechoic compared to the more echoic spleen, as you can see here. In fatty liver, it's vice versa, bright liver, dark spleen. In comparison, the fatty liver to the kidney might be disturbed by the attenuation of the ultrasound beam. But you can improve by reducing the frequency, by reducing the dynamic range, by optimizing the persistence. So finally, we get a pretty good image also in a fatty liver of deeper located structures. There's one sign which is almost seen in all patients, and it's a distinctive sign. You see focal fatty sparing, which shows typically centrally located arteries. And those centrally located arteries next to the arrow in contrast-enhanced ultrasound will give to that hypoechoic areas the pathophysiological explanation. There are more arteries, less portal vein branches, less insulin, less fat, and therefore they are also explained as a typical sign of fatty liver. If you use shear wave elastography, here point shear wave elastography, those values are normal, comparable to the surrounding liver parenchyma. So there is no increased fibrosis. The flow pattern normally is triphasic, but in fatty liver, monophasic. So there are quite a lot of ultrasound signs in fatty liver. And now we introduce technologies, and the first on the market are shown. Strain elastography is compression elastography. I will not talk very much about that. and we will talk more about shear wave elastography with 3 different techniques: the transient shear wave elastography, the point shear wave elastography, and the 2D shear wave elastography. Here you can see a normal lymph node with a hilum, soft tissue, and you can see a malignant infiltrated using compression elastography, strain imaging, and this has been applied also for the liver, but much more often used are other forms. As already introduced, it's transient elastography by fibroscan, and you can indicate the fibrosis using the measurement in meters per second and transferred into kilopascal on the right side. And as already mentioned, you can also measure the attenuation. Physically, the shear wave is measured as a velocity which can be calculated and transferred into kilopascal by the formula shown. Point shear wave elastography is the technique to measure the grade of fibrosis, and on the right side you can see the velocity indicated. 2D shear wave elastography has eventually the advantage of having a wider field of liver parenchyma to give more reproducible and more representative tissue samples. 3D has been also described, but is not currently routinely used. As mentioned, we have to think about quality parameters in each technology used. And here shown in a Hitachi equipment, they have their interquartile range measurements, and you have to follow the manufacturer's instructions for their quality measurements, which is often above 90%. Point shear wave elastography and 2D, in this case measured by Siemens Acuson Sequoia. You can see that we measure 0.9 meters per second, equivalent to 2.4 kilopascal. And using the 2D, you can see pretty much the same 0.93 equivalent to 2.6 kilopascal, that those measurements are comparable. Most importantly, but we might discuss later on with the clinicians, is that the prognosis depends on fibrosis and not on the amount of fat. And this has been shown by Angulo and many others, that here you can nicely depict those signs with fibrosis, red and green, as the distinctive factor between the amount of fat. So the amount of fibrosis is the distinctive prognostic factor. Coming back, the prognosis depends on fibrosis. Then this has been summarized in the EFSOM, European Federation for Societies of Ultrasound Medicine Biology, EFSOM guidelines, which you can free download from the EFSOM and WFUMB, World Federation for Ultrasound Medicine and Biology website. I will give a few recommendations. Measurement of liver stiffness by point shear wave elastography and 2D should be done at least 10 millimeters below the liver capsule. There is a high level of evidence for that. And then there should be a fast for a minimum of 2 hours and a rest at least for 10 minutes. Most importantly, shear-wave elastography within the normal range can rule out significant liver fibrosis. That's the most important clinical recommendation with a high level of evidence and high consensus. Intermediate ranges are much more difficult, which is not only true for histology. As you can see here, using a liver biopsy, the biopsy can identify the fibrotic strand as shown here, but can go through the fibrotic strand and prove liver cirrhosis, or can hit parts of the fibrotic strand, and therefore histology may show if the fibrotic strand is located liver cirrhosis, or it can even show pretty normal liver parenchyma with only to the left or right of that fibrotic strand liver parenchyma is examined. The same is true for ultrasound, and the different methods have been compared, and the intermediate stages in different technologies, depending on from age, depends also eventually of the amount of fat a little bit, and so on. The intermediate stages are much less easy to compare. 10 measurements should be done by point shear wave elastography and transient elastography. 3 are enough for 2D. It best performs to rule out cirrhosis, and this is true for transient elastography, point shear wave elastography, and 2D shear wave elastography. All about normal values and how to compare is written in this review. And errors, we have to look for stiffness due to fibrosis, but also inflammation, nutrition, cardiovascular disease, congestive heart failure, body position, and others have to be taken into account. Screening, let us start early. This is a baby less than 1 year, 35 kilos. You even can't believe it. And we have to think about influential of the nutrition status, or in such small children, we have to think about sedation. But if you play with that child, you get comparable data. Might it be with the fibroscan used or the 2D shear wave elastography as shown here? So we perform a study on children to observe the amount of fat and the early recognition of the fibrotic stage. Research priorities in the future should go for the cut point for each modality, the validation of quality criteria to compare better, the clinical meaningful increase-decrease of liver stiffness, which is mostly linked to the clinical outcome in non-alcoholic fatty liver disease as shown. It's the fibrotic stage, not the fat amount, and the cost effectiveness of whatever we do, eventually followed and included magnetic resonance imaging, but magnetic resonance imaging is still a research tool. So I have shown the ultrasound signs of steatosis. We have been introduced elastographic methods. We have shown that technology are different in different machines and technology used, but in the edge to exclude or to prove liver cirrhosis, they are pretty much comparable. The techniques in one equipment are comparable. The prognosis depends on fibrosis, not on fat. Different etiologies and age groups have to be taken into account. The method is best to rule out liver cirrhosis, second best to confirm liver cirrhosis. Open questions are in research, the intermediate stages with different equipments. So finally, everything is written in our guidelines, as mentioned. Thank you so much for your attention. I'm looking forward for the discussion.